Greetings, everybody. Oh, Ahmed, are you there?
Hi, Hi, dear John. Can you hear me?
Yeah, how you doing, Ahmed?
I'm good.
Okay,
I'm just sharing the post for attending the lecture.
okay, you got the camera working? The camera working?
For sure. Just a minute.
Hello, everybody. We see a lot of Arabic names I don't usually see, which is great. There's Ahmed.
Yeah. Hi, dear John.
How's it going? No, I know that Salim checked in with me a few minutes ago. How about Patty? Did he check in at all?
Yeah, yeah. Of course. A few minutes early, and he asked for the log of the lecture. So I think now he is preparing for the lecture.
Okay, I'll just introduce you and you run the show, right?
Of course, as we do usually. Okay.
Yeah, and you can moderate the questions and you know what to do. You're an
Sure.
experienced host.
Of course.
Take that pin off.
Just check if Professor Salim will join us.
So how's residency going?
Mm-hmm.
Yeah, you're open to do more, Ahmed. Whatever you want to do, okay?
But
You're welcome to do more if you want.
it's my pleasure. By the way, after 3 weeks, I think, or just 2 weeks, there will be a webinar with Professor Ibrahim Spey and a neurosurgeon from Yemen
Great,
about
great.
cranial.
Just let me know ahead of time, no problem.
Mm-hmm, sure. And by the way, as I always say, that without your support, we can't do anything. So thank you so much for your support and for your help. I
Well, I'm
mean,
trying to get support now from the pharma, from the other medical companies, which I think they've always supported education. I think it's a matter of being persistent, showing them that this platform is good advertising for them. That's what I have to show them, because it's new to an advertising. It's a new area. They know what it's like to go to a conference, of course, and have a booth and talk to the people, but they really don't know online stuff. You know what I mean? So,
sure.
so, trying to make it attractive to them. So when I go to people like you or someone else, I don't say to you, okay, can you fund this? I say, no, we have an opportunity. The costs are covered. And what would you like to talk about? You know, which we get sponsored. The concept of sponsorship. Just take it out of the hands of the doctors. So the doctors can what they do best, which is to speak and to get speakers together and get a good webcast together.
Absolutely.
For you to chase around the hospital looking for money, it's tough. It's tough. It's tough for every country.
For sure, anyway, I think there is a problem with me in the internet. Can you see my camera very good?
Yeah, your background's a little hazy. Oh, this fatty had fatty.
It's just a banner, and I don't know if you can see it good, but
Well, Martin's
it's
here.
okay. Just a minute to check.
Well, Salim's here.
Professor Chabell,
Hello, Dr. Chabell.
Prof. Abdurraf is also here. Let me promote her to be a panelist. Promote him. Sorry. Now I think.
Hello, hi, Fadi. Hi, John.
How you doing, Salim?
Good to see you guys.
Hi, dear Professor.
Good to see you. Good to see you all.
You are muted, Professor Fadi.
Okay. Yeah, I was saying good to see you. Okay.
Good to see you.
So you guys been busy?
Yeah, John, we can hear you.
Oh, you can hear. Hey, how you doing there, Martin?
Yeah, I'm fine. Hi, Abdul Raf, how are you?
Good to see you, Martin. Good to see you all. It's good to be here.
Yeah. Remember you came here a couple of years ago down to Dubai to start the Dandy?
Yes.
That was good. That was good.
Yeah. Thank you.
We all remember that. That was a memorable night.
Thank you, Martin. Thank you. So good to see you. So good to see you.
Martin, have you met Fatty yet? Fatty,
No, I haven't actually. No.
Fatty, this is Martin Woodley. He's in Dubai.
It's nighttime there. Looks like.
Yes, it is. It is indeed. And it's morning in America, right?
It's noon.
Yeah.
It's noon.
It's noon in Chicago, and it's something else somewhere else, I suppose.
Isn't that what President Reagan used to say? It's morning in America.
Okay, you guys ready?
No comment.
All right. No comment. All right.
Okay, you ready to go, you guys? Salim and Fatty?
Okay.
Yes.
Ahmed, okay, Ahmed, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett broadcasting from sunny Miami Beach. We have another in the Walter Dandy, Yemen, with the ambitious Ali Ahmed Al-Ghanemi moderating, and we'll let him take over the show. Good day, Ahmed.
Hi, dear John. Thank you for introducing me. It's my pleasure and honor to have this webinar with high-level neurosurgeons around the world. If you permit me, I'm gonna start with Professor Salim. He is the president of the Walter E. Dandy Neurosurgical Society and also a professor in George Washington University. So, hi, dear Professor. So I don't know if you will start first or just...
Either way. Fadi, what's your timing like? Do you want to go first or second? It's okay. How long is the session, Ahmed?
You can say 30 to 40 minutes. If you,
okay, so I can do the 30 minutes. Is that okay with you, Fadi? Okay, cool. All right, so I'll go ahead and start. Thank you very much, John. Thank you, Ahmed. You are doing an amazing job. I mean, we're so impressed by you. Yemen is a country, it's had a lot of difficulties, and despite that, you have shown tremendous leadership, and you have done, really, we're very impressed by what you're doing. So let me go ahead and share my screen, and I say hello to all the colleagues from around the world. Just so Martin from Dubai, was great to see him, and the colleagues who are joining on Zoom and YouTube. So we'll go ahead and get started here. So I'm going to time myself so I stay to exactly to the time, so we respect the speakers and the audience. I'm just going to, today the subject is about bypass surgery. I want to give you an overall view about my thinking about bypass surgery and my personal journey in it, actually. So getting right into it, the fundamental part of bypass surgery is learning how to do an anastomosis. Learning how to do an anastomosis comes in the lab, not in the OR. A lot of practice on rubber tubing has to happen before doing an anastomosis in surgery. Okay, the simplest way, having a rubber tubing, you could do this in your when you're not using the OR or whatever, use a microscope and understand how you put sutures in a way that's systematic. The problem is surgeons in general, when you're tying a knot, you're going up and down because you're tying with your fingers down. The problem is vessels that have very thin walls. You cannot tie like you normally, tying a fascia or muscle, whatever, you will tear it. You see, the force is all lateral, this way and this way. It's never up and down. So that's principle number one, is to know which way your force is when you're tying a knot on a vessel. And secondly, you need to know, how to do these square knots without turning your hand 100 different positions. So for example, if you're right-handed, you go in, and this is true if there's a vessel that's bleeding, same thing. You pull it with your right hand, okay? Then you hold the stitch with your right hand and make a loop. Making the loop is what you need to get very used to. Then you pull it, then you hold it with the other hand, and you pull it through. So, the force, the vector of the force, and then secondly, how you minimize movements under the microscope by how you hold either end and make it very easy is the way to get comfortable with this and how you handle these situations. So, of course, this requires a lot of practice, and we're going to be doing a big bypass course later this fall at GW. You're welcome to come and practice that as well with us. Dr. Chabell and I used to do a pretty big course every year with a number of colleagues in St. Louis for many years. We're going to restart that here in DC. So I welcome you to join that. Why do we need to know this? Well, there are a number of situations. This patient has ischemia from occluded M1, okay, and is developing a number of ischemic episodes. You look at the STA, okay. So going back here, you see, you gotta figure out which branch you're gonna use, okay. Which branch you're going to use and where it's going to be safest. If they're both are equal, you want to be not on the forehead for sure, okay? So you want to get a branch, you got to dissect it long enough to bring it in for your anastomosis, okay? You need to check the flow. There is a Chabell flow probe, which is very helpful. Then you make the vessel diameter as big as you need to be the same size as your arteriotomy, okay? So here you see what I'm doing is size matching both of them, okay? So this is size matching right there, okay? And this allows us to then do what I just showed you a minute ago, okay? Same thing under the microscope. you become good at it, you feel comfortable, and you start putting your stitches and so forth. So that's really, you got to get comfortable with this from that perspective. So this is how this has to look like an elephant foot or a fish mouth. So that means it looks very good. It's wide, it's not tight, it's not tiny little anastomosis. It has to be very wide. And then you check your graft with flow, as Dr. Chabell will talk about, and just make sure that, this is the ICG showing that, the anastomosis is working, there's flow going to the brain and so forth. So this is what we call low flow bypass. And, you have to get very comfortable when you are dealing with anastomosis deeper, when you're going around the circle of Willis. You got to be very comfortable with opening the sylvian fissure very widely, where you're comfortable with it, and expose all the vessels. Exposure of the vessels becomes an important thing. Let me show you here. So for high flow bypass, which is a different ball game, we're using a graft, a radial artery, to anastomose historically, traditionally in the neck to the cervical carotid. This is the recipient branch, as you see, same technique, all right? And then essentially, this is the anastomosis to the external carotid artery in the neck. This is a traditional anastomosis in the neck that has been done. I have moved on to use the internal maxillary artery, and I'll show you that in a minute. But this is a standard traditional bypass, and you attach your radial artery. Of course, this high flow bypass, we don't use it for ischemia. We use it for flow replacement if you're occluding an intracranial vessel because it has, let's say, a fusiform aneurysm on it. But same technique applies here. And then you come intracranially, you do the same thing like we talked about. You heparinize inside the vessel, and you will then attach the vessel like I showed you already here, the same way we did it. Sorry, I have to move fast because I just want to cover a few things in my segment here. Essentially, the anastomosis we're talking to you about, it's an anastomosis in this case to the radial artery to M2 or M3. Technique is the same. I showed you interrupted stitches. There are running stitches, so there's multiple ways of doing that. And as you get familiar with it, you'll learn a lot of little tricks of the trade. It's a lot of little tricks we've learned over the years. You do not, you start with learning the low flow bypass before you start doing any of these high flow bypass, because these are really kind of a little higher risk procedures. And, I think being familiar with that in a stepwise fashion is the way to go here from that perspective. So this is a high flow graft using the radial artery like I just showed you here. And then, this has significant breadth to it. You can go all the way to the carotid, as you see here. In certain situations, that is where the anastomosis needs to be done. Optic nerve, carotid artery, so we're doing an anastomosis here for a giant aneurysm. This whole thing is aneurysm here, extending intracranially, extracranially, this we're replacing flow by anastomosing to the carotid artery here. Okay, so that's okay. So as we move along, I'm just going to move to. So as I moved along in my practice, a couple of steps that you saw in these procedures that bother us during surgery. For example, so here we have to occlude, for example, this internal carotid artery for an amount of time for me to do the anastomosis. How do we know how long the patient will tolerate this temporary occlusion? This is step one, that is high-risk step, okay? This is all behind me is the aneurysm, okay? So if we were to say, okay, we're doing EEG, SSCP, neurophysiological monitoring, PAMA do neurophysiological monitoring, it has about 20% false positives and negatives. And it's variable based on the neurophysiology, person, how they're measuring, and so forth. So the first issue I'm worried about, if I'm going to occlude somebody's carotid, I want to know they can tolerate it for the length of stuff. And we've done a lot of, research on this issue, and we found out if you can really tolerate carotid, if you can occlude the artery for 2 or 3 minutes and it tolerates it, then it's very unlikely you're going to have a problem in the next 10, 15 minutes for these larger vessels based on our data. So I thought, instead of doing this with the patient under general anesthesia, if we are to do it awake and I do awake testing where I test the patient, I know the answer to that question up front instead of me guessing. The second step is, after you've done your anastomosis, now you want to occlude the parent carotid artery. How do you know 100% your graft is carrying enough blood and there is not going to be a problem, even though you put a graft in? You normally in general anesthesia, we occlude the parent vessel. But now, as you will see, I will do a test occlusion awake, test the patient for 10 minutes, make sure everything's okay before I occlude it. So that is the concept that we have moved to from this perspective. So if you look at this here, this patient has this fusiform aneurysm that he had a rupture from it, okay, going all the way into the MCA, all right? Now I'm going to do, he did not have radial artery. Okay. So
we're typically ranging from.
So we're
15 hertz.
although I'm doing it awake, I'm still doing the monitoring. This is a part of a study. You see, I'm testing the patient before I put the temporary clip. I put the temporary clip on and I tested the patient. The patient.
Well, that's good.
All right. So you see, he's talking to me while I'm doing this anastomosis because I already tested it. And he is tolerating the vessel occlusion, which is great. Now I know I'm doing okay and there is no problem. So that's the issue, the advantage. Now when I'm occluding the carotid artery after I bypass a fusiform aneurysm, how do I know my graft is carrying enough blood flow? Okay. So you see, I'm testing him for 10 minutes. Can you do it for Jody? Can you start it?
Don't move.
Okay, so 10 minutes with a hypotensive challenge. And hypotensive challenge, make sure that if my graft works, we're dropping the blood pressure, okay? I want to make sure 100% before I occlude his internal carotid artery. Okay. So, of course, we stand under the shoulder of giants. Professor Yashigo, was the first to perform the ST-MCA bypass in the late 1960s. And just to get to, I just want to get to the, because of time here. Essentially, for ST-MCA bypass, traditionally, you do a whole craniotomy. That's how Professor Yashigo described it. With the emergence of the of image guidance, I thought how we could make it a little bit more doable. So with image guidance, we identify the donor vessel. We identify the recipient vessel. Okay, so we don't need this big craniotomy. It's a tiny little opening that can do this. You see, that's it right there. So for this low flow ST-MCA bypass, that's all you need because you've already identified your donor recipient, and that's a bypass right there. Okay. That's opening right there, okay? So it does not need to be a big operation. Now with the awake, patient is awake, small operation, this is really has become a very, very kind of a simpler procedure. We published our, this technique early in my career of a very minimally invasive kind of situation. Then you have to think outside the box sometimes. This is a patient who came to me from Qatar. He had severe Moye disease, sickle cell disease, had a number of strokes. Well, the problem is he does not have an STA, superficial temporal artery. This is actually the middle meningeal artery. So you have to think outside the box. I ended up then using the middle meningeal artery instead of the STA right here, okay? You see, I identified the middle meningeal artery, and that's the middle meningeal artery there. That's an anastomosis to the MCA. That's a graft right there. And that's a patient a few days later in my office. So sometimes you have to think outside the box. You have to think of ways how to achieve what you're trying to do, okay? Now, early in my career, a lot of really senior neurosurgeons helped me push myself in cerebrovascular surgery, and you really give me the strength to proceed with this. So when I started doing high flow bypass, the vessel that most people were using, the generation before me, was saphenous vein. I ended up scrubbing in with heart surgeons, number of cases who were using the radial artery. I found the radial artery to be much more similar to intracranial vessels. It didn't have valves. So I started to really push this issue. We had our meetings early on. Dr. Chabell remembers this. People from all over the world as we're trying to look at this issue, and training people. And for example, this is a massive, it was sent to me as a meningioma. This is a giant aneurysm. And so we started thinking, okay, how to make it better, this procedure. So so this was my first case. I used a radial artery in the situation. We published our experience using the radial artery for high flow bypass. Dr. Shaker was doing the same thing. And this started to develop really quite a bit after that. And I believe a lot of people are using the radial artery now. The problem with this procedure, that it's very big. It's big incision in the neck, big incision in the head, big incision in the arm. So I started to think, what is the next step? How can I make this procedure slightly less invasive? So I started to look at the maxillary artery, the internal maxillary artery, okay? Because I was doing skull-based tumors and I used to run into it quite a bit. So I was thinking, instead of going all the way to the neck, can we make this procedure slightly less, not as big? We did a large study looking at the maxillary artery in the lab. We did a lot of work looking and identifying it. We published that. And this was the first case ever of a maxillary artery use in high flow bypass for a complex aneurysm. So extradurally in the middle fossa, this is a maxillary artery. We bring it in. Now attach the radial artery to it. Okay. Bring the radial artery. I don't have to go to the neck except a small incision to occlude the carotid at the end. But this bypass is just here. That's it. So we don't have to have such a long graft going to the neck, which theoretically, the physics of vascular surgery, the shorter the graft, the better chances of non-thrombosis, okay? So this was the first case that we ever did. This was published in Neurosurgery as a cover article. I'm honored that a lot of my colleagues, vascular neurosurgeons, call this as the Abdroff bypass. I'm humbled by that for sure. And then, of course, a mentor to a whole generation of us, Professor Spessler. He's the one who, in his book, put the name Abdroff to it. So I'm honored by that. So anyway, so these are the cases. We start to look at the maxillary artery quite a bit, okay? And it's this loop of the maxillary artery that touches the middle fossa floor that is critical to bring you from there to here, okay? Instead of going all the way to the neck, we go from here to here. So that was my evolution personally in trying to do this. Just another case showing you the maxillary artery right there, extradurally in the middle fossa, beautiful. You bring it in. It's a loop, so you put your temporary clip here, you got it, you can work with it. So it makes it, so I exclusively use the maxillary artery now for bypass where you need a graft, except in situations where the patient doesn't have a good maxillary artery or is very small, of course, and that kind of thing. So this is my case's standard bypass from all the way from the neck to the brain, and this is now my case from maxillary artery here. You see the difference in what we have accomplished with this fact. Anyway, I mean, there are a lot of little evolutions we have been involved with. a group of us, vascular neurosurgeons, including Dr. Chabell, who've always tried to push the technique in how we could make this better for us. So we devised longer instruments. This is doing a bypass to the P3 segment of the posterior cerebral artery, subtemporal for a coiled, a large basilar tip aneurysm that ruptured. So I'm attaching the radial artery to the PCA. But for this, you need binetted instruments. You have to have different curves on them. And so, some of us are involved in devising the right instruments to be able to do this kind of anastomosis this deep, as you're seeing here. And that's the same thing we started the lecture with right there, okay? So that's takes us to that. So that's a bypass right there going to there, okay? So we created a new artery to the PCA so that we can clip this here, okay? So we created this artery here, okay? So this brings me back to the issue of, especially Moya patients, when you put them under general anesthesia and they hyperventilate, the CO2 goes down. These patients are at a high risk of problems as far as ischemic injury during surgery, right? Whereas if you do it awake, it's the opposite. Your CO2 is going to be very high because they're awake and that kind of thing. So that really helps with that. Plus, I told you the other benefit of temporary occlusion time, okay? This is a patient that was sent to me as a consultation after the very experienced neurosurgeon did this operation, and they had this problem under general anesthesia where the patient developed a large stroke, and technically the procedure was done very well. This was due to hyperventilation, CO2 in a very ischemic hemisphere to start with, okay? So to me, these are the things, the lessons I learned. I think I can just show you step by step how we do a procedure like this, putting everything I talked to you about so far together, okay? First is the maxillary artery, okay? And that's a maxillary artery right here, okay? I'm going to identify it, okay? It's right there. It comes up. Right here, comes closest right there, okay? I catch it right here, okay? It's fine. Harvest the radial artery under regional block. So this is a harvest. My chief resident and my fellow each doing one thing. So radial artery harvest, cranial opening, small opening in the neck for occlusion of the artery at the end. That's the radial artery. First, we perform the anastomosis to the maxillary artery. Here, we don't have to worry about temporary occlusion because the maxillary artery, of course, does not supply the brain, and there's no problem temporary occlusion. This part, I'm not worried about, okay? So this, we attach it to the maxillary artery. That's the first thing I do extradurally, okay? Then we check the flow, and Dr. Chabell will talk about this, okay, in a minute, quantitatively. And we got the flow, okay? Now, one of the two steps that I worry about, number one, we're going to attach to this MCA, this division. How do I know how long she will tolerate closure of this vessel? How safe is it, that length? Okay, let's find out. I'm going to put a temporary clip, and then I'm going to test the patient. Okay.
Lift her hands.
So I do a testing just to know what's going on. How good are the collaterals around this vessel? Now, somebody would say, okay, well, she doesn't tolerate. What are you going to do? Well, I'm going to go to another vessel. I'm going to go to a vessel until the patient can tolerate the temporary occlusion. So generally what happens, if one doesn't tolerate it, the other division, the branch in that area will tolerate it. That's been my experience. So I need to know that up front. Okay. Now I'm attaching my radial artery to that branch. I'm very happy. Patient is doing well. Actually, patient is talking to me while I'm doing this. So that's fine. Okay. Now I say the graft is nice, is good. All right. What is the next big step? I got my graft. I'm all happy. And I'm, bypassing a big area. Now we're going to, under general anesthesia, we just go ahead and occlude the internal carotid artery. In this case, I'm going to do a temporary occlusion test, okay, with the patient to make sure I'm 100% comfortable. So I'm going to occlude the internal, okay, and temporarily, and I'm going to test the patient for 10 minutes, make sure that the patient can tolerate that my graft is working very well. This is a patient that failed balloon occlusion before surgery.
Yeah,
Okay.
squeeze my hand again. Yeah, raise your hand.
Okay, so we're testing for 10 minutes, hypotensive challenge. Now I'm very happy. I can occlude the artery. I'm 100% happy. I know everything is fine. Okay, so this is the small steps that we have added small over time to kind of guarantee our outcome before we leave the operating room, which is an issue, of course, of concern in high flow bypass. Finally, I just want to show you the data that, you know, we are, because of this awake craniotomy for complex aneurysms we're doing, it's part of a study, the OMTA trial. We had to do 30 cases for phase 1 and show that it was very safe, and actually comparing myself to general anesthesia myself, my outcomes were a lot better. Okay, so this allowed us to move to phase 2. This is the protocol for the various aspects of the awake procedure for the consent of the patient. And then we did phase 2 of this, and this is based on electronic health record, where the committee, the central review committee, looks at all the outcomes based on electronic health record, blinded everybody. And what we saw, because we have 2 arms, awake and general anesthesia, that for complex aneurysms, we found that in this central review, prospectively, this is not for simple aneurysms, but only for complex. There was a significant change in morbidity and mortality of patients who are undergoing treatment of these fusiform or large or giant or calcified aneurysms. Many things in neurosurgery, this is pretty significant change actually in outcome standpoint. Now we're in phase 3, which is multi-center study. Okay, and this is an interim analysis, multi-center studies showing that our the difference is remaining. Okay, these are the kind of aneurysms that are included in the study. Okay, and as you see, still there is a significant difference between the control group under general anesthesia and the awake group, still remaining as the study is going on currently. Interval analysis, this was for that. So I think with the time, I'm coming close to the end of my time here for my portion of the talk. This is the motto I believe in for all the young guys listening to this lecture, young guys and gals, neurosurgeons of the next generation. This is what my parents instilled in me, and then my mentors as well. You leave things better than you found them. Wherever you go, whatever institution you work at, whatever kind of procedure you do, how can you leave it better than you found it when you walked in? That is a principle that I have worked with throughout my life. And for as far as bypass, that has been close to my heart in dealing with complex aneurysms, and I've done the things that I felt that have been helpful as far as outcomes are concerned. It's not just me. There's a great number of colleagues in the United States, around the world, in vascular neurosurgery, who have done amazing work to improve this whole area. So we're indebted to all of them and to our mentors. I'm very proud of my book, Cerebral Revascularization, where we looked at the whole concept of bypass surgery. All of my colleagues I just mentioned all have chapters in this book, and we continue in this road. Bypass is perhaps more important now than it was maybe 15 years ago, because now endovascular treatments for complex aneurysms are requiring many cases to need bypass. So you have to, this is a skill set that is very important for a vascular neurosurgeon to develop with. And the next generation has to know this is a set of skills that if you have the skill, it can get you out of a lot of trouble situations. So it's been my honor. Ahmed, great job you're doing in Yemen. It's my honor to be on this panel with Professor Fadi Chabell. And John, thank you for your work for us to transmit these lectures around the world. Sorry I went through this pretty fast, but we really want to respect the time of the session and the speakers, please. Thank you so much. All right.
Thank you, Professor, for this outstanding lecture. And for your kind words for me that push me forward and support me as usual. So again, thank you so much for your support. Okay, I think there are some questions in the chat. If you can check
Sure.
it, sir.
Yeah, just make sure for Dr. Chabell's time. Okay. I'm not seeing the questions on this. Did you? Oh, it is in the chat. I'm sorry. Okay. Of course. Hello, everybody. Okay. The question is, meningeal artery anastomosis, is there any evidence or trail of microanastomosis in meningioma? Yeah, so the meningeal artery, I just mentioned it just to think outside the box. We have only done 5 cases, and I think that's really all that there is in neurosurgical literature. This was in the extreme case where you need to do a direct anastomosis in moya patient that has an STA that's missing, and the MMA is big. So my team, the residents here, are putting together that paper right now, or 5 cases. I mean, our experience is very limited, and let's be honest. I mean, it's just out of the 5 patients, 4 had still open graft in long-term follow-up angiogram. Okay, but I think it's only it's an issue, a extremely rare situation, extremely unusual situation. You would consider doing something like that. The next one, at any part of the radial artery. So the radial artery experience is very wide among your heart surgeons in your hospital. So before you think about doing that, please go talk to them. They know how to do this very well. And then once you get good at it, your residents can do it. It's a nice practice for the residents. And there is a test before surgery that we do, the Allen's test, with the Doppler and with the arch, and we check the flow, that there is a good ulnar flow. You have to know this test very well before you take somebody's radial artery, and it's so the heart surgeons. Okay, Alejandro Chavez, surgery in the thrombosis cave cerebral middle artery, for example, before meningeal surgery in thrombosis of case. I'm not understanding the question, Dr. Chavez. Thrombosis cave. So I have not shown any cases of tumors here. There are very rare cases that are these malignant meningiomas that keep reoccurring, invading the carotid. We have some experience with bypass for that, but in general, I mean, we don't have large experience with the tumors for which we do bypass. That's usually extremely limited, very extreme indications that come up with that. So, but yes, for MCA, yes, for MCA. Stenosis or occlusion in a symptomatic patient based on perfusion study that they are symptomatic, not from embolic disease, but from flow, then yes, I think those are reasonable candidates. A lot of testing has to be done. And I think Dr. Chabell will cover that a lot better than I will. So I think I'll turn the floor over to him from that perspective.
John, are you over there?
Okay, Martin, do you have any comments or questions? No, you're okay. Okay, it's all yours, Ahmed.
Thank you, Martin.
Okay, now I think we have to go with Prof. Fadi. So Professor Fadi Charbel is head of neurosurgery department at Illinois hospital at Chicago. So, dearest professor, can you hear me?
I hear you fine.
Yeah, welcome, sir.
Okay, well, congratulations, Dr. El-Ghanimi, for putting this together. I want to echo what Professor Abdul Rauf have said. It's really impressive. I don't know how things are going for you there in Yemen. All we hear is in the news that there is a difficult situation. So I can only imagine that this is not easy. So you get a lot of credit for doing this. And we're happy to help in any way we can. And of course, Dr. Bennett, who's been doing this for a while, great job. Thanks for doing this and for the invitation. I will start my slide now by putting my PowerPoint here. And if you don't see it, let me know. So I'm
It's
going to
okay.
talk about, thank you, is aneurysm surgery. My screen here has, can you see the top of my slides or are they cut
Yeah,
off?
perfect.
Perfect. Okay. So aneurysm surgery is still alive. You can still do it. I'm going to give you some examples of what I do. My disclosures is related to the flow probe, which bears my name. When we consider aneurysm surgery, there are 12 steps, and they are listed here. And after you do step 1 and 2, which is the incision, the craniotomy, really the very first step is proximal control. So once you approach aneurysms, you can design the approach, and the very first thing you got to think about is proximal control. Next thing is you want to think of where the neck is. You got to have a clip in mind. If you can, get distal control. Assess the flow and the vessels at risk. Identify what they might be. Mobilize the dome. That's a key part of the surgery. Clip the aneurysm. Recheck the flow. Perform an imaging study, ICG, DSA, whatever you may have, and then make sure that the aneurysm is excluded. So I'm going to go through this process with you. This incision and the craniotomy, of course, has changed over time. You see here the classic large craniotomies. Now my approach for all anterior circulation aneurysm is what I call the modified lateral supraorbital craniotomy, inspired by the late mentor to everyone, Juha Hernesniemi. Juha popularized the LSO. My modification is I do not drill the lesser wing, I do not drill the pterion, and I don't cut the muscle. So that's what it looks like. It's a small craniotomy, about 1.5 to 2 centimeters. And with that, I can do just about anything in the anterior circulation. The goal of this surgery, of course, for aneurysms is to exclude the aneurysms from the circulation, whatever procedure you do, open, endovascular, that's the goal. And you got to do that while preserving flow in the distal branches. So how do you look into that from a thought process? You got to identify the vessels that might be at risk, and you got to check before and after. You can check visually, of course. You can do an angiogram, ICG, angio. You can do a physiological measurement. We do all of that, but physiological measurements are very important. This is the flow probe that you heard mentioned previously. And the key with that is you can have a vessel that's patent on an angiogram, but that has compromised flow. So this is a series of 100 patients that we published a while back now. And you can see that about a quarter of them, even though they look okay, the flow is compromised. But by detecting this flow change, you can correct this problem and avoid a complication related to flow compromise. So we use it. It's part of our armamentarium. I'm going to show you a simple aneurysm here of the middle cerebral artery. Focused splitting of the fissure, opening the fissure further with a little injection of saline. Of course, the next step is going to be what? Proximal control, right? So we're going to identify the M1. You see the M1. Then vessel at risk. Here's one of the branches of the MCA. Now, here's the aneurysm. The step here that's being performed is mobilizing the dome. For small aneurysm, it's very, very critical to do that, like with any aneurysm. But for small aneurysms, there's not a lot of aneurysms to clip. So you got to really release all these arachnoid bands so that when you put the clip, it's not going to pull the aneurysm together with the vessels adjacent to it because of those arachnoid strands. So this is done sharply. Sharp dissection is safer than blunt dissection. And once all of this is cleared, now the aneurysm is free. You can see it's a fragile aneurysm, fairly typical of what they look like when they're small like that. Now we're checking the flow in the other branch at risk, 2 branches of the MCA. And then the clip is being considered here with the right hand. It's a good clip, but the angle is better. You'll see I'll use the left hand to apply it. And then once the temporary clip is placed, even though it's a small aneurysm, you see it's fragile and it's good to have a temporary clip. I'm placing the permanent clip with my left hand. What you're going to see here is I use a forceps to pull the clip in the aneurysm rather than pushing the clip onto the vessel. That is more precise placement. The temporary clip is removed. We check the flow again. And once this is done, you can see that we're able to do all of this through a 1 centimeter fissure exposure. So I do not split the fissure completely. Now, what if there's something more than that? Here's a patient that has 3 aneurysms, a previously coiled ACOM aneurysm, a right MCA, and a left MCA. And we clipped all of these through this approach that you see here, modified lateral supraorbital, here in this case, starting on the right side. We're going to split the whole fissure because we're going to go all the way from right to the middle to the left. So once we expose the right side aneurysm, we continue. Of course, for multiple aneurysms, you clip the deepest one or the more distal one first. And now we're reaching across to the sylvian fissure on the left side. Got to split this fissure here. And then we're going to see this aneurysm. We're going to clip it, small aneurysm on the other side. Now we reach the ACOM aneurysm, which is pretty complex, has coils in it. You see the coils and start to clip it. Of course, an aneurysm like that has a high risk of vessel compromise, so flow measurements are critical here. See, I'm measuring flow in the A2s. I reposition the clips. I use other clips. I measure flow again. It's important to, with every step of the way, check and make sure the flow is preserved. That's the beauty of this instrument. Now we're done with that. We go to the middle cerebral on the right side. There are 2 aneurysms, almost at right angle to each other. Temporary clip on the M1. Pull the aneurysm into the clip. Clip applied with the left hand. Aneurysm is deflated. Cutting it to make sure it's dead. Same thing for the other aneurysm. Deflating it, and that's the size of the craniotomy. And you see the postoperative angiogram in this patient. That's the craniotomy. CT scan looks great. And this patient went home the next day. So you can do a lot of things, and the importance of minimally opening the dura, disrupting the brain is key. That's a pericallosal aneurysm. You see here that the dural opening is limited because there was a vein right here. So this very limited approach, we're able to do everything. We're going in the interhemispheric fissure, see the aneurysm, we measure flow, we clip the aneurysm, we measure flow again, and this is a 7 millimeter dural opening. So all of that can be done through a very, very narrow corridor. Okay, let's go to step 8, which is key mobilization of the dome. Why is that important? Look at this aneurysm here, very common nowadays. Clipped, recurred, growing, previously ruptured, so right-sided approach. You see this vein here that's being dissected. You don't have to preserve it, but I think it's a good thing to do. And here's the exposure. Very complex aneurysm now. So we're checking the flow at baseline in both A1s and both A2s. You see the coils, they're out of the aneurysm. So the next step is identifying the neck. See the neck's being identified on both sides. We gotta try to tease these coils out, but it's not possible to do without cutting them. So we gotta cut them sharply, as you see that, and we're gonna mobilize the dome. So this is to highlight mobilizing the dome, which is very, very important. If you don't do that, you can't clip the aneurysm properly. Now, sometimes you wanna put a pilot clip. Here in this case, I didn't. But once the dome is mobilized, then you can really investigate how to clip this aneurysm and preserve the perforators. So here's one clip that was placed. It's a decent clip. It's a pilot clip. It gathers the aneurysm, but it's not a perfect clip. And what I do here is I call a 2-hand clip technique. So with one hand, I have the best clip, and with the other hand, I remove the other clip at the same time without losing the space. So I use both hands, and that's how we get this aneurysm under control. a little bleb from the other side, checking the flow. Here it is. That's the full extent of it. That's the view. You see the brain looks pristine. You see the vein still preserved, postoperative angiogram. Again, highlighting this technique, this two-hand technique. See this very high pica aneurysm, high-riding pica aneurysm. It is almost at the level of the internal auditory canal, very large vertebral artery on the right side, measuring flow in it. So difficult to temporary clips. You really have to be precise here. Retromastoid craniotomy to clip the aneurysm. You see this aneurysm has a branch adherent to it, very stuck. Can't mobilize it, checking the flow in the pica at baseline. And I put the first clip, which gathers the aneurysm together. You see it's partially clipped. It's good. It's pilot. But now I'm going to use this two-handed, double-hand aneurysm clipping technique. See, this is the better angle to apply the clip. So I got it. And now I can remove the other clip and preserve the space that I have put in here and advance the clip. And that worked out very well. Check the flow again. Then, of course, we also check ICG. You see that little branch here that looks very happy. Again, small craniotomy. Now, this is an aneurysm that had been previously clipped. Huge craniotomy. You see the size of the craniotomy. Incompletely clipped. My craniotomy is a tiny piece of the big craniotomy, even though it's much more complex surgery. You see the clips are here. It's previously ruptured, incompletely clipped. So we really had to take care of this, remove all these clips here, get them all out of the way. And then as these are clips, you got to clean everything, dissect everything. You can do it. Same principle. Here's the M1, temporary clipped on it, and permanent clipping. And here's the postoperative angiogram. So smaller craniotomy is good. All right, why do we mobilize the dome again? Because there can be something stuck to it. So you see here this aneurysm, which looks simple. There's a branch going around it. My fellow had clipped it, and you see the ICG that shows that this vessel is patent. But once we check the flow in it, the flow in this vessel after clipping was 1.6. I wasn't happy with it. Check the flow after releasing the clip. And what is the flow? 3.9. You see that a vessel that is patent is compromised, even though it looks patent. So how you got to do that? You got to mobilize the dome. And what's the problem? See this vessel? It's attached to the dome. So when the clip went on the aneurysm, it did not clip the vessel, but it stretched it. It pulled it. So you got to mobilize it again sharply. You got to mobilize this vessel sharply. And as you do that, you release it from this vessel. It is free now. It goes out of the way. And now you can clip this aneurysm properly. So adherent branches, of course, is a big problem. See this one here? I'm trying to dissect it. I want to show you another way to deal with it. I'm dissecting it, but it's just not feasible. It's very, very, very adherent. You see that? It's very adherent. So what am I going to do? One part of it has been dissected. The other part is pretty stuck, as you see there, and the aneurysm ruptures. So what do? I'm going to put a temporary clip, and under temporary clipping, you see the rupture point here. I'm going to coagulate it. It's a little very fragile blood, coagulated. So that stopped bleeding. It doesn't last long, so you got to put a little clip on it at the rupture point. And at that point, I got to decide, well, how am I going to clip this aneurysm with this branch stuck to it without compromising the branch? So I put a pilot clip. And after putting a pilot clip, one thing you can do, if this aneurysm cannot be dissected from the branch, cut it. And this way you free the branch with a little bit of the aneurysm. And once that is done, then we can temporary clip again, and then apply a better clip and take care of the aneurysm. And you see how at the end, the branch is still attached to a piece of the aneurysm, and the aneurysm is well secured. And one more example, you see this branch here, very, very stuck to the aneurysm. Again, same thing, you see small craniotomy. And the first thing I did here is I, of course, split the fissure, focused manner. And there's a vein first. You see there's a little vein here that was adherent to the sac. Of course, dissect that. Then there's another branch. I dissect that. But there is a third branch that is very adherent to the aneurysm. And even though I mobilize the dome, you see this branch here, this branch right there, very, very adherent. So I dissect it, very stuck, fragile aneurysm. There are 2 blebs around it. I dissect it. I'm working on it very patiently. It starts bleeding. What am I going to do? What I'm going to do is I'm going to say, forget it. The branch is there. I'm going to cut the branch. I'm going to get it out of the way. I'm going to clip the aneurysm and then resect this aneurysm. And then what I'm going to do is I'm going to take this branch and reconnect it. And here it is. So we're reconnected at the end. Now that the aneurysm is out of the way, you see the sac of the aneurysm, it's been cut and removed. So now we connect this branch that was in the way, and here it is. And here's the branch, and of course, you see the ICG, and the branch is patent. So there's different ways, different example to show you how you deal with this. That's the final view here. And the last point is, how do you know that the aneurysm is secure? You can look at it, you can do angiogram, but the angiogram is not a foolproof thing. Look at these things here. All of those aneurysms with ICG that looks like the aneurysm is dead were still patent. We published that. So look here at this aneurysm. You see how it's dark on the ICG down there? I'm going to cut it. Look what happens. This aneurysm is still alive. So how do you know that an aneurysm is secure? You won't know for sure unless you cut it. But before you cut it, you can do something that we published when I used to teach the live surgery course in Padua, and I call it the squeezing maneuver. So look at this aneurysm here, was clipped. And then after it was clipped, you see the ICG looks dead. This is the squeezing maneuver. Just squeeze it before you cut it. And many times you'll be surprised. The aneurysm is still alive. So now you can correct your clipping before cutting the aneurysm open. And of course, at the end, once the aneurysm is dead and you're sure with that, then you can cut it open. And here's another example of the squeezing maneuver. It's a pericallosal aneurysm complex because it has a branch stuck to it. It's a very fragile aneurysm. It's a callosomarginal branch that's stuck to it. So the way to deal with it, I got to cut this branch. I got to re-implant it. I'll show you this again here. I cut this branch. As you see here, I'm going to re-implant it on the other vessel. And once you do that, here's the anastomosis. This aneurysm becomes a simple aneurysm. It is simple, but look, even though the blades of this clip are across the aneurysm, is it secure? Checking the flow, looks good. Is it secure? Well, it was not. And I'm going to show you this one last time, that once we do that and we do the squeezing maneuver, look at this aneurysm here, it looks dead. Watch what happens. You squeeze it, it's still filling. So it was not secure and it required an additional clip like that. So these are the 12 steps of aneurysm surgery. You see them listed here. Some steps go iteratively, like you can mobilize the dome, clip, then check the vessels, etc. And that's our university. That's our institute in Chicago. That's our new lab, beautiful new lab, most beautiful lab in the world, won the award for that last year. And hope to see many of you there. So thanks for asking me to share with you. It's really a pleasure to see old faces and new faces, to see Salim, and congratulate again Dr. El-Ghanimi for putting this together. Wonderful effort.
Thank you, Professor, for the amazing and informative lecture. Actually, I am so lucky for having you with us tonight and to have this lecture with Your Excellency. By the way, there will be a conference in Egypt on December. So I wish we can meet over there with Your Excellency and with Professor Salim and all the attendees. So I wish to meet you soon face to face, sir.
I have a question for both of you. You're doing wonderful work. You really surpassed Ghazi Yazegin. But anyhow, if in this setting that down here in the Middle East, especially in Yemen and places, if you had to choice to you could just choose 3 aneurysm clips which ones would you choose? I mean, your hospital could just afford 3 aneurysm clips.
That's a great question, and I've been in these situations. Basically,
I
what
mean,
I
as
travel,
many as you want to apply, that's, you know, that
yeah,
helps probably. But
yeah. Basically, what I when I travel and there's really no aneurysm that you can't clip with a straight clip. It's just nothing. And and Salim is shaking his head in approval. Yeah. There's no aneurysm. You don't need to be very, very fancy. You can remodel the neck. You can do different things and just clip the aneurysm. So basically, you have a temporary clip. Now you got to make sure you have a temporary clip because you can't use a permanent clip as a temporary. That will injure the vessel. And you know, a 7 millimeter, a 10 millimeter, and a 12 or 15. And with that, if you have these 3 sizes, that's plenty enough. You can take care of everything. What do you think, Salim?
I agree, Fadi. Yeah, totally. Yeah, I agree with that.
Okay, Ahmed, are there any other questions, Ahmed?
Martin, you're on mute. We couldn't hear what you said.
I don't know if there is a question in the. Okay, someone raised his hand a few moments before me. Go back. Anyway, if there is anyone want to ask any question, you are welcome to ask.
Muhammad. I'm with you. I'm Dr. Momin for Bangladesh, and I'm nice to hear such an excellent session from Bangladesh. And I also try to come, inshallah, try to meet with everyone this time. And I also invite all of you Bangladesh in our next session, SCNS, BSNS, at 3 May 2025. Assalamu alaikum.
Welcome to Bangladesh. Okay,
Okay,
Ahmed,
sounds
I
like
guess.
we kept on time. John, what do you think? Are we ready to close?
Yeah, I think we're ready to wrap up. What do you think, Ahmed?
Yeah, to me it's all. But I would like just to invest these moments to thank you, John, for giving us this opportunity for getting this amazing webinar with the Professor Fadi Charbel and with the Professor Salim Abdurraouf. And I wish we can have another webinar and other webinars, in the coming few weeks with them and others. So again, thank you, Professor Salim. Thank you, Professor Fadi Charbel, for this opportunity and these amazing lectures.
One thing I'd like to
Pleasure to
say,
see all of you. Great to see you, Salim. Thank you very much.
one thing I'd like to say to everyone is that we're kind of changing the format. We're having the didactic presentations, and then we're having actually presentations by the sponsors after the didactic. So look to see that. Okay, thanks everyone for coming. See you next time.
Thank you.